Thank you very much for the kind invitation. So this is my second lecture. I can change, no problem. Which is on clinical challenges of OPLL management. I have no disclosures relevant for the presentation, and I identified mainly 5 challenges for managing OPLL. The first one is diagnosis. We need some degree of imaging awareness. OPLL is calcification of the ligament, which is different from calcification of the annulus, of a disc. And this leads to reduction of the canal and spinal cord compression and neurodeficits. And obviously, the main diagnostic criteria is imaging. And here we have a problem, because most of my patients, they will come to us with an MRI and not with a CT anymore. So, for example, this kind of patients, if you don't do, this is the same patient, if you don't do CT, you may miss the diagnosis. Radiographs per se have a very low inter- and intra-observer reliability. So we need proper CT with 3D reconstruction is the most sensitive diagnostic method. Sagittal sequences will help also to classify the OPLL. Detailed visualization of ossification boundaries is crucial for selection of the appropriate treatment and surgical technique. What about the incidence? More common in male and aged people. We thought this was really a disease from Asian people, and data shows this. But when you apply also different techniques like the CT, incidence depends on the imaging method. And in 1,500 healthy Japanese, look how it doubled the incidence of the discovery of OPLL from radiography to CT. And among non-Asian population, it's 2.2. So it cannot be viewed anymore as a disease of Asian populations. And we start to see it more and more in a country like mine in Portugal. It's really important because you have a high incidence of spinal cord injury in those patients. In this study, spinal cord injury with OPLL happened in 23% of the patients, and most of them had no injury. It was no bone injury, it was just a trivial fall. So, and only 20% of those patients were aware that they had a PLL. So prevalence of OPLL among spinal cord injury was alarmingly high, especially in those without bone injury. The largest epidemiological study done, patients being submitted to surgery, the symptomatic OPLL had a mean JOA of 9. This is dramatic. And a JOA of 11 was the most common indication for surgery. If you look at this prognostic factor based on MJOA, baseline MJOA, you see that there is a ceiling effect. The more severe pre-op, the less likely will be the recovery after surgery. So we are diagnosing too late those patients. This paper I found interesting regarding clinical awareness. It's a diagnostic model using machine learning method. Patients with OPLL had higher surgical risk and poor postoperative recovery, so early detection is essential. And average age BMI was higher in patients with OPLL. Mean ASTY were elevated. We don't know the meaning of this, but this is interesting. And what would be then the alternative strategy? To do CT scans to everybody, asymptomatic patients? I don't think so, because this would cause unnecessary anxiety in patients. Most radiographic detected patients are asymptomatic, and the proportion of spinal canal occupied by OPLL is small in those patients. And surgery is only advocated if there is a rate occupancy canal more than 40 to 60%. There is certainly no consideration for prophylactic surgery in those patients. The second factor is OPLL is per se an independent risk factor. In this study, a systematic review with more than 1,500 patients, the overall incidence of surgical complications in OPLL was slightly higher than 20%. So there is a high incidence of surgical complications with OPLL compared to other degenerative myelopathies. So you need to communicate with patients when making your decision and alert patients for complications when you do surgery on those patients. This study shows that the presence of OPLL is a significant risk factor for perioperative complications like operating time, post-op drainage, CSF leak. Again, CSF leak higher in OPLL surgeries. The dura ossification, which is a very intimate adhesion of dura to the ossified PLL mass, can happen in almost 30% of patients. And the double layer sign has a good specificity for that. So there is also high rate of failure dural tears treatment in patients on OPLL. And you have to develop strategies to minimize, and the anterior floating method can be one strategy. On the other hand, this meta-analysis also showed significant higher palsy, C5 palsy in patients with the OPLL. Axial neck pain is a significant complication, and also superficial site infections. On the other hand, this study, sponsored from Mayo Spine, found no difference between OPLL and no OPLL patients. Stratification risk, are all OPLL patients equal? We have a bone window CT-based classification, segmental, continuous, mixed, and localized type. Increased expression of bone morphogenic protein 2 was noted in continuous and mixed type. Patients that tend to be just more asymptomatic, they have 60% of them, 60% are of segmental type, and mixed and continuous type, they have a greater percentage of canal stenosis and increased risk of trauma-induced myelopathy in the mixed type. These other studies show no difference. So we really need good classifications to predict which patients will tend to develop fast myelopathy. For example, if you have a continuous bridging OPLL, this patient seems to be more stable because there is less range of motion, and motion is also a problem in the development of myelopathy. You have different types of classifications. The unblocked type, it seems that OPLL is fused. The heel-shaped OPLL, more compression, laterally deviated OPLL, more chance of myelopathy. And dural defect is associated with non-segmental type of OPLL. So you need to understand those factors to identify high-risk patients, to counsel the patients, and to develop avoiding problem strategies. OPLL progression, it's a problem. It's defined as increase in longitudinal extent of ossification, more than 2 millimeters. You have the criteria here. This means most of the patients' neurological deterioration. If we have OPLL C2, C3, C4, there is a risk of progression. Age, also less than 60, and continuous type, also OPLL progression, which is dramatic because these are younger patients with higher life expectancy. And the type of surgery also has a role in the OPLL progression. As you see here, laminectomy alone 62%, laminoplasty 45%, and fusion 30%. So it's, in my opinion, a good criteria to offer fusion to OPLL patients, especially if they are young patients. Timing of surgery and approach. In this study, it's 11 studies, 480 patients. OPLL were treated non-operatively with a quite large follow-up. Myelopathy progression occurred in patients with already myelopathy. Almost half of them progressed to myelopathy. If they don't have myelopathy, only 16.7%. So conservative treatment for patients without myelopathy symptoms and canal stenosis less than 50%. Also, it shows that the chance of spinal cord injury is higher if you have OPLL, 2 times higher. Speaking about surgery, OPLL surgery via any approach is associated with higher complication rates, surgical morbidity, and the reoperation rate, still better anyway than conservative treatment. The timing, there is a window. The compressive surgery is a standard of care for symptomatic OPLL, ideally with a jaw inferior to 15. Still lack of consensus regarding the time and choice of surgical approach, but time is crucial. OPLL is a modifier for the selection of type of surgery. In my experience and according to the literature, anterior approach is most effective tackling the problem because it addresses the compression, but is also the most risky and the most demanding and higher rates of dural tears and nerve injury. Posterior approach is generally lower rate of complications, but a low disease progression. So the choice of approach is influenced by complications of each procedure. This systematic review showed, this meta-analysis showed that anterior corpectomy, higher postoperative jaw recovery than laminoplasty. Better post-op final jaw scores, functional recover with anterior surgery, especially if you have high occupancy rate in the canal. Look at also at the K-line. If K-line is positive, there is a significant higher recovery rate compared to negative K-lines. And you can have negative K-lines because the patient are either kyphotic or have a very thick ossification. Neuro recover after ADF, anterior decompression and fusion, is superior to laminoplasty if you have a pre-op kyphotic alignment. Again, the same data. With the posterior approach, laminoplasty, not only you progress the disease, but you have also progression and of the loss of lordosis that you gain. And we are starting to look at other data. Patients with pre-op cervical, high pre-op cervical SVA tend to have sagittal imbalance and neurological symptoms. So this is a bit the kind of algorithm that we can use, less than 2 levels an anterior approach, more than 2 levels. You look at the occupation ratio of the canal, if it is higher than 60%, if you have a negative K-line, kyphosis, it is flexible or not, you address if flexible from posterior, if not flexible, you have to probably combine. If you don't have kyphosis and neck pain, go for laminectomy and fusion, no neck pain, laminoplasty. So, for example, this patient of mine, less than 3 level, high canal occupying ratio, lordosis less than 10 degrees, K-line negative, pre-op neck pain, I address it from anterior. So conclusions, OPLL is best diagnosed by 2 and 3 dimension CT imaging. You should have a high suspicion rate to prescribe a CT. As I said, most of my patients don't show up with CTs anymore, so avoid underdiagnosed or mistaken for milder forms of degenerative calcification. It is an independent risk factor for myelopathy progression and worse surgical results. There is still a lack of standardized and reliable classification that will help us to stratify patients. It's essential to identify those patients for OPLL progression and implement appropriate preventive surgical strategies. The optimal timing and approach is still controversial. Thank you.